Welcome to another Otolivia video, this time talking about cochlear implantation and what differentiates the various cochlear implant electrodes. Let's start with some basics. So if you have your cochlea and you look at a cross-section of the 2.5 turns, you'll see this tree-looking structure where you can see that the lumen of the cochlea is divided into 3 compartments, and each of them are innervated by an afferent nerve, all of which feed into the trunk of this tree-like structure. All of these nerves together are called the medialis. If we blow up one section of cochlea, you can see again the 3 compartments and the organ of Corti, which lies in the scala media, and the afferent neuron running from the basilar membrane along the spiral lamina towards the medialis. The 3 compartments of the cochlea are the scala tympani, which terminates at the round window membrane, and it's called the scala tympani because the round window membrane looks like a timpani drum. The scala vestibuli terminates at the vestibule, where the stapes inserts. The scala media houses the organ of Corti and is filled with endolymph. Unfortunately, a thorough review of how the cochlea works and these different compartments is outside the scope of this video. Today's cochlear implants are designed to be passed through the round window membrane and into the scala tympani. Lateral wall electrodes lie along the lateral wall of the sinus tympani underneath the organ of Corti. Lateral wall electrodes are thin, reliable, and easy to insert with a one-handed insertion. They're a bit far from the target because although they're close to the organ of Corti, the target of CI stimulation is really the afferent neurons. There's also a small risk of electrode migration due to their flexible nature. The perimedialar electrode was designed to sit closer to the target, hence the name perimedialar, so it limits cross-stimulation. So what is cross-stimulation? If we have an electrode and its various electrode contacts, here you can imagine that the contacts, when they're firing, release a fan-shaped stimulus. And if the nerve or the target is very close to the electrode contact, then they get a very focused stimulation. But if the nerve or the target is very far from the electrode contact, you can have all these areas of cross-stimulation where the multiple contacts can cause stimulation to the same position on the nerve. This limits the typical tonotopic organization of the cochlea and the afferent cochlear nerve that we're trying to mimic with the cochlear implant. So in order to achieve this perimedialar position, most models, but not all, use pre-curved methods which risk a bulkier, more traumatic insertion. The mid-scala electrodes are designed to sit in the middle of the scala tympani. They are also pre-curved to achieve this positioning and sit relatively close to their target. There are 3 main manufacturers of cochlear implants in the US: Med-El, Advanced Bionics, and Cochlear Americas. Let's start with Med-El. Med-El creates several lateral wall electrodes in their Flex series, which are generally named based on their length. The 34 is the longest electrode. Then comes the 31.5 millimeter length, referred to as the Flex Soft. Then there's a 28, 26, 24, and 20 millimeter electrode. Med-El even has a compressed 12 millimeter electrode array, which can be used for abnormal anatomy. All their electrodes have 12 electrode contacts, 7 of which have bilateral contacts. These are inserted simply by advancing them through the round window. To help you properly orient the electrodes, the marker they have for you should be oriented superiorly, or dot at the top. So these are all lateral wall electrodes, and which you choose depends on the size of the cochlea and distribution of hearing loss. In patients with excellent low-frequency hearing, some surgeons opt for a short 20 millimeter electrode to provide hybrid hearing. This implant will cover primarily high frequencies, leaving the mid and lower frequencies untouched. So the patient hears through a hybrid of the implant for high frequencies and their natural hearing for lower frequencies. However, increasing literature supports still using a full-length electrode and just attempting hearing preservation in these patients, because even with the short electrode, you risk losing residual hearing, and if their hearing loss continues to progress, then you're stuck with a short electrode that doesn't cover all the frequencies. Aside from that exception, the length is recommended based on the size of the patient's cochlea. Med-El offers a program called Otoplan, in which they use a high-definition scan of the temporal bone to calculate the cochlear duct length and recommend an appropriately sized electrode. Lastly, cochlear implant insertion robots, such as iotamotion, are compatible with all lateral wall electrodes and are commonly paired with Med-El electrodes. Advanced Bionics is another implant manufacturer, and they have 2 commonly used electrodes. First is called the Slim J. This is a lateral wall electrode with 16 contacts. There's a blue line which allows you to visualize a complete insertion intraoperatively when it reaches the round window. There's also a little wing as an insertion handle. The wing should be oriented inferiorly during insertion. You can remember this by how you draw little gull wings pointing downward. The second electrode is their mid-scala model. This is a styletted electrode. It also has a wing, though it has a slightly different shape, which should also be oriented inferiorly during insertion. This electrode has two blue lines. You insert the electrode through the round window to the first blue line. Then grip the stylet and advance the electrode off the stylet until the second blue line reaches the round window. Without the stylet, the electrode springs into its pre-curved shape. This electrode also has 16 contacts, 5 between the tip and the first blue line, and 11 between the first and second blue lines. If there's a tip fold over or incomplete insertion, it can be removed and the stylet reloaded up to 3 times for repeated attempts. Cochlear is the third manufacturer. They make 3 commonly used electrode models. First is the 1012 model. It's also called the Contour Advance. It's a perimediolar electrode whose shape is controlled by a stylet, much like the Advanced Bionics mid-scala electrode. Cochlear electrodes have 22 contacts, and ribs, which signify a complete insertion when they're at the round window. There's a fin, which should be oriented inferiorly during insertion, or fin to feet. You insert this electrode through the round window until the white marker line is at the round window. Then grip the stylet and advance it off stylet and into the cochlea. Their next electrode is the 1022, also called the slim straight electrode. This is a lateral wall electrode with 22 contacts. There's also a fin which should be oriented inferiorly during insertion. As with other lateral wall electrodes, you simply advance this one through the round window. There are 2 white lines which tell you the insertion depth. If you stop inserting when the first marker is at the round window, it's been inserted 20 millimeters. At the second mark, it's been inserted 25 millimeters. The third electrode has a more complex insertion mechanism. It's called the 1032, also known as the slim mediolar electrode. This is a perimediolar electrode which is pre-curved without a stylet. It uses an external sheath to control the curvature for insertion, so the electrode itself can be thinner since it doesn't have to accommodate a stylet, which is thought to be less traumatic and is the reason for its namesake, the slim mediolar electrode. However, this electrode has a higher tip fold-over rate than other electrodes, though it is still quite rare. If that happens, it is also reloadable. There are 22 electrode contacts and an orange and white sheath. The sheath has a handle on it which should be positioned superiorly, so sheath superior. To place this electrode, you insert the sheath through the round window and hub the rib. Then advance the electrode through the sheath until the 2 white lines match up. Then you remove the sheath. All Cochlear brand electrodes have an additional ground electrode which needs to be placed, and we typically put it anteriorly under the temporalis muscle. Let's do a quick overview on the surgical procedure for cochlear implantation before we get into actual electrode insertion. For greater detail on the surgical approach, see my How to Mastoidectomize video. This is a left ear. We start with a skin incision and then make a T-shaped palvoflap before drilling. A cortical mastoidectomy is performed and Kerner's septum is taken down to identify or open the antrum, where you can identify the lateral semicircular canal and short process of incus. Then you can start opening the facial recess between the incus buttress, facial nerve, and chorda tympani nerve. This allows you to visualize the round window membrane where you're going to place the electrode. Now that you can see the round window membrane and trust that you can place the cochlear implant, you can open the device and start creating a pocket for it. Let's draw out where we're trying to put this. You're drilling your mastoidectomy cavity here, and you want the implant to go roughly at a 45-degree angle, superior-posterior, to your cavity, with the electrode ultimately curling into the cochlea. We don't want the implant to be wiggling side to side because that can cause the electrode to dislodge or migrate. So we take advantage of a couple of cranial sutures where the periosteum is tightly adherent in order to create your tight subperiosteal pocket. Anteriorly is the squamosal suture line, and posteriorly you have the parietomastoid suture, which gives way to the lambdoid suture. So what you really want is to place your implant between these suture lines in order to minimize device migration. Placing it above the temporal line, which is dotted out in red, also prevents the device from shifting downward. So here we're using a Cobb elevator to get underneath the temporalis muscle between the squamosal, parietomastoid, and lambdoid sutures. Avoid too much elevation to keep your implant snug. With the device in place, you're ready to open the round window membrane. Ideally, you'll wait to open the round window membrane until after the implant is placed to avoid blood and other debris getting inside the cochlea, which can impact hearing preservation. First, we'll demonstrate the lateral wall electrode placement. This is a Med-El electrode, but as you heard from the description, most of them are similar in terms of how to place them. You can see it's a very thin, basically flexible noodle in this left ear. Superior is oriented to the right side of the screen, and so the surgeon has to grasp the electrode so that the gentle curve is pointing superiorly in line with the basal turn of the cochlea. On Med-El electrodes, remember that the dot goes at the top. Once you maneuver the tip of the implant into the round window, you slowly advance it until the dot is just outside the round window. You can see it clearly here now that the dot is at the top and hubbed at the round window, so we have a complete insertion in the correct orientation of this lateral wall electrode. For the styleted electrode, hopefully you can appreciate that this one is less flexible and a little bit more rigid, so it's easier to insert the tip into the round window niche. This is the Advanced Bionics mid-scala electrode. So the surgeon inserted until the first blue line was at the round window, and then gently released the implant in order to reorient their hands. Now it's time to advance the electrode off stylet. So the surgeon grips the stylet with their left hand and the implant with the right hand. Holding the left hand steady, they push with their right hand for a full insertion until the second blue line reaches the round window. The blue lines are somewhat hard to appreciate on the recording of the microscope. Lastly is the insertion sheath technique. This is the Cochlear 1032, also known as the slim medallic electrode. So you can see here that it's a pre-curved electrode that we then retract back into the sheath before we get started. The first step is to just place the sheath containing the tip of the electrode into the round window. You hub it at its little rim, and then you can let go of the electrode and reposition your hands. Note that the little arrowhead on the sheath is superior, aka sheath superior. The electrode is advanced inward until the white rim on the electrode meets the white rim on the sheath. At that point, the sheath can be removed, and you can see deep down the recess that the white markings on the electrode are just adjacent to the round window, signifying a complete insertion. The Cochlear brand implants have an additional ground electrode that you have to place separately, so here we are placing it under the temporalis muscle anterior to the implant. Regardless of which electrode you do place, you want to coil the excess into the mastoid cavity. I find that the easiest way to do this is to aim for the additus, but you don't want the electrode touching the incus or it can dampen sound in cases of hearing preservation. I want to take a moment and talk about exposing the round window membrane. So if we're looking into our facial recess, we have the lateral semicircular canal and short process of incus. Within the facial recess, you can see the pyramidal eminence attached to the stapedius tendon. The incus long process is extending from the epitympanum, giving rise to the lenticular process, which attaches to the stapes capitulum. The visibility of the stapes is variable, but I'll draw out the posterior crus, anterior crus, and footplate for completeness. The width of the oval window is about 2 to 3 millimeters. That same distance separates the oval window from the round window. Here's the promontory and the round window membrane for reference. But the round window often isn't perfectly visible like that. Often there's an overhang, usually on the superior side. You'll need to drill that away to expose the entire round window membrane. The scala tympani travels antero-inferiorly within the promontory towards the pars ascendens. The scala vestibuli follows a parallel path from the oval window. Between them lies the basilar membrane, which you don't want to violate. So you can safely drill postero-superiorly and antero-inferiorly to expose more round window membrane or even some of the membranous labyrinth along the basal turn. If there's no visible round window, an independent cochleostomy can be performed along this orientation using the oval window as your guide for the approximate location of where the round window should be. Once you're outside of the round window membrane annulus, you're performing an extended round window approach. Here's an example of a partially ossified cochlea without any residual hearing. The round window was obstructed by pseudomembrane, but clearing the fibrous tissue demonstrated a true round window membrane. The visibility was poor, so the posterior superior overhang was drilled, followed by the anterior inferior wall, creating an extended round window along the basal turn. While that was a large enough opening, the electrode still wouldn't thread up the pars ascendens due to fibrosis in the scala tympani. So we intentionally opened the scala vestibuli by drilling antero-superiorly. You can see us manipulating the basilar membrane to open the scala vestibuli widely. The electrode thankfully passed easily through the scala vestibuli. Thanks for watching. There are, as always, downloadable reference materials highlighting all the different electrodes and their features. Just click the link to the Google Drive in the video description.